the island and further afield. Donna was saying earlier that this is one of the first years that she is also not in Dublin for this weekend. But I think we've done some nice events so far, and we have a few more coming up. So I suppose I just take the opportunity to thank the providers for the provider panel for joining us of a sunny Saturday to take part. I'm really grateful, and I'm really looking forward to the discussion and to hearing from you. So the first speaker we're going to hear from is Dr. Tiernan Murray, who is a member of Doctors for Choice. He's a committee member and has been since 2013, and he's also a community provider of the early medical abortion since January 2019. So thanks for joining us, Tiernan.
Can you hear me there?
Yes.
Okay. Will I start?
Yeah, that would be great. Just curious to hear about your experiences sort of since 2019.
Yeah. Okay, so the story I bring is a story of extraordinary success in provision, and I think we should all stand back and see how wonderful that is. And all of those who have fought through activism, through ARC, through the years, have seen their hard work result in a wonderful service whereby women in Ireland have safe, legal, free abortion with choice of provider. If I'd been asked, certainly in about 2015, what I would have hoped for in the best possible scenario with Repeal the 8th, I couldn't have believed that we could have such a service. So I think we should all feel good about the fact that everybody's hard work has given the women of Ireland the service we wanted them to have. The majority of abortions in Ireland are carried out in the community, certainly more than 90%. And the success of the programme can be illustrated by the fact that you hear nothing in the newspapers about it. Up to January 2019, the question of abortion was in the newspaper every day for about 2 years. And you hear nothing about abortion anymore. So something must be working really well if the newspapers can't make a story out of it. Community provision is basically general practice throughout the country, plus the other providers like family planning and Well Woman. And I checked with Mary Favier, who founded Doctors for Choice, a week ago about how many providers we have. And we have 375 providers. She gave me that figure last week. Now, actually 5 new providers have joined in a week. And that number will slowly, inexorably go up. And what's interesting is before the service started, we confidently predicted that if we had 300 providers dispersed geographically well around the state, we could provide a very good service. Now, that number, we've exceeded that number. And as time goes by, the number of providers will grow and grow as the service becomes more normalized, and probably as a cohort of senior male GPs who perhaps, own practices around the country and perhaps are limiting the number of young GPs who wish to provide from doing so, begin to allow those young GPs, who interestingly are 80% female, and almost all young female GPs are well trained in LARC. And so for them to provide the EMA service is just a very natural extension of an area they work in already. So the number problem is not there. The way we work as providers is under an umbrella group called START, which has been an extraordinary success in terms of information sharing and support. So START is the group of providers, mainly GPs, but other providers in family planning and well woman, but also a few obstetrician gynecologists and midwives. And it's a tremendous support because, say we have a new provider, a GP who's single-handed in rural Ireland, starting the process, a bit unsure, a question to everybody. For instance, they may want to access the local services for a woman patient who they might be unsure what the hospital service is like, how they're going to be received. So they pop the question on the WhatsApp, and within about 10 minutes, they will get clear, scientifically validated information, which might be, for instance, just ring Mary, the midwife in the local hospital, and she will sort out the problem. So it is tremendously supportive. In terms of problems, well, there were always going to be three obvious problems, which are still there. The first one is the 3-day wait, which infuriates me because it's the only part of medicine where an adult will make a decision about their own healthcare, and the doctor has to say, will you go away for a few days and think about that? Nowhere else in medicine does that happen, and it shouldn't happen here. We've had to live with it, and it is a barrier. And if we could get the legislation changed, even if it said a 3-day wait is ideal, but if the doctor and the woman felt immediate provision was in her best interest, that the doctor could proceed, that would solve the problem. It has been helped by the event of telemedicine, whereby when COVID came, we were given permission to do the first visit over the phone. And that has helped. Although generally speaking, doctors really like to see people in person. And this isn't just in EMA provision, but in all areas of general practice. But at least we do have the option of doing the first visit over the phone. The second problem all along was that of protesters. And the government promised us they would do something about that and didn't. My experience is that since January 2019, I have a group of protesters outside my office between 10 and 11 every Saturday, with their obvious posters. In fact, when COVID came, they disappeared, but I was surprised passing my office today that they were back. I had thought at level 3 that you're supposed to avoid all unnecessary social contacts, but these people didn't think so. It's not a problem for me. I'm not open on a Saturday. Most my patients are horrified by this. But it was a problem in the early stages, particularly along the border. And it was very difficult for the early providers with protesters outside their offices, many of them busing over from the north. And I think those providers were very brave to stay the course in the face of that. I would have thought that with time, the protesters would simply go away, but that certainly didn't happen today. The situation of women from Northern Ireland, which again, I think is a disgrace. All women in Northern Ireland are entitled to Irish citizenship. A large number of them have Irish passports, and they should not have to pay for accessing this service. It wouldn't cost this state much for our taxpayers to pay for them. Now, hopefully, with new developments in the north, hopefully BPAS will be able to provide a service up there and that they will not have to travel south. And that's the ideal solution. A little small one that developed that we didn't foresee was access to scans. So scans are free, and the government contracted with private X-ray facilities to provide the service. But the service has been patchy. I know, for instance, in Cork, the provider simply stopped providing the service for 2 weeks at one stage without notifying any of the providers. And I think more HSE oversight is needed, whereby if the taxpayer is paying these private companies for the service, they really need to provide the service. One little thing that popped up was a question about the provision of PPS numbers. So to access free EMA, you need to have a PPS number. There are other small categories of women who may not have a PPS but are legally in the country, such as overseas students. And if they are legally in the country, they can be provided with the service. But if the woman does not have a PPS, the provider is not paid. Now, there have been experiences around the country where a woman may well be entitled to a PPS, but has not accessed it. And practice managers have phoned up and got a number over the phone. So that was great. In other practices, GPs might take a deposit and tell the woman that if she comes back in the next 3 months with a PPS number, her money will be refunded. And finally, there is the situation of pro bono work, that all GPs through their lives at times do work for free because we have patients who are not entitled to free services and have no money. And I'm certain that's happening as well. I'm not sure how you get around the problem of the small number of people, perhaps illegal migrants who do not have PPSs. I don't know how that's going to be fixed. In relation to hospital services, I'm not going to talk about that because I don't work in a hospital. I'm again looking at Holles Street, and there is a fantastic service in Holles Street in a department called the Annex, where Lorraine and a partner have a clinic Monday and Thursday. And if we have the slightest problem, we can email in a request for the woman to be seen, or we can simply phone on a mobile. So to me, there is no problem. But of course, around the country, it's not so easy, but I can't really address that. So that's all I want to say, and well done to everybody for getting us to this place. And I'd certainly be happy to answer any questions. And if anybody feels that there is a problem in community provision, I'd love to know, and the others in the START group would love to know. So please speak up. Thank you.
Thanks so much, Tiernan. If people do have questions for any of the speakers, if you want to just type them into the chat box, and then we'll get back to them sort of after everyone has finished giving their presentations. And also, I just wanted to highlight an action that we're asking people to participate in, and it's about you know, statistically speaking, sometimes abortions will fail, and so the action that we're asking people to take is to contact their TDs to make sure that anyone who experiences this isn't then obliged to travel to the UK to complete their abortion, that they're allowed to do that here, regardless of whether they pass the 12-week mark or not. And so I've asked Danielle to share the link to that petition in the chat box as well. But if you're unable to find it or anything, we've been sharing it on Twitter and on our Facebook page as well. So do please share any questions that you have with us. There will be time at the end for some Q&A. So I'll just introduce Alison now. Alison is with the IFPA, and she's their policy officer. She's also doing research about sort of the experiences that people accessing the service, the EMA through the IFPA are having. She'll be much more able to explain her own research herself. So I'll just hand you over to her now. Thanks, Alison.
Thanks, Kathy. Can everyone hear me okay? All right. Well, I suppose to start, just to say thanks to ARC for the invitation and also for organising this discussion, and the whole kind of weekend of events to mark International Safe Abortion Day. I think we all know from international experience, you know, in countries like South Africa, Colombia, the United States, like advocacy and activism are crucial for maintaining and enhancing access to abortion. So I think spaces for dialogue amongst all of us who have a stake in the provision of abortion care are really valuable. So as Kathy said, I work for the Irish Family Planning Association, or IFPA. I'm not a provider myself. I'm the Policy and Research Officer. So what that means is I work with our clinic staff to collect and analyze data about the abortion service and to kind of translate the experiences of our clinic staff and service users into advocacy messages for members of the Oireachtas and other policymakers. So yeah, I've kind of structured my comments loosely around 3 questions, which is, you know, kind of what's working, what isn't working, and where do we go from here? And I have some suggestions about potential ways forward, and very interested to hear from people during the discussion about their own perspectives. So to start with the boring bit, which is the law. So sorry if there's any lawyers for choice people watching. And then I'll move on to kind of the IFPA's experience of provision. So I think, you know, the group of us here today, it's probably fair to say that like this isn't the law that any of us dreamt of. You know, I don't think anybody participating here, you know, went out looking for a mandatory waiting period or retention of criminal sanctions or a 12-week gestational limit, you know, when we were knocking on doors in 2018. And I think that the legal framework falls short of what a lot of us envisaged. And it's really not the law that should have followed such a kind of resounding referendum result. And I don't want to kind of dwell too much on that, but I do think it's useful for us as activists and advocates to think about how our political asks were translated into law by politicians and civil servants, and what we can kind of learn from that as we move towards the review of the law next year. So I've been criticized definitely by activists in different countries, like colleagues in kind of Belgium and Croatia, for like my negativity about the Irish experience, which I'm thinking of particularly, you know, after Tiernan's remarks. And I do agree that the service is overall a success story. And I think on the face of it, you know, repeal was a spectacular achievement. You know, there's no denying that. But I think it's kind of in the nature of advocacy and activism to identify the problems, to spot the gaps and to highlight them. And I think there's kind of a tension in that as well for us, because like, you know, this is a new service, like its very existence is politically contested. So I think we need to kind of walk a line of like vocal support for this service, and then also demands for changes where those changes are needed. And I think all that said, the law in many respects is working really well. And I think in recent months, we've seen potential for the regulatory framework to expand in ways that are patient-centered and rights-based. I think the experience of the pandemic has actually opened up a space around the abortion law and the model of care that we wouldn't have otherwise seen. But I think the opposition know this as well. So from the IFPA's perspective, I suppose, as a community provider, there's a lot of things that are working well. I should say there's a couple of caveats to this, which I think Tiernan referenced as well. So although we provide specialist pregnancy counselling in 10 locations around the country, our clinical services are based in Dublin. So we've 2 sexual and reproductive health clinics, one in Dublin city centre and the other in Tallaght. And these locations mean that we're very well served by maternity hospitals, and we have good referral pathways as a result. And we know that this isn't the experience across the country, right? So only 10 out of 19 maternity units are providing the full range of services. And that means that some community providers don't have the benefit of a local referral pathway to secondary care when needed. So I just want to, I suppose, give an overview of what our service looks like. It's accessible through the HSE My Options helpline or by contacting our clinics directly. So we offer early medical abortion up to 9 weeks, and that's 9 weeks plus 6 days. And then referral for hospital-based care for people who are between 10 and 12 weeks. And that's 12 weeks plus 0 days. So those 2 interpretations come from the Department of Health, not from service providers themselves. And I think certainly for us, that interpretation of 12 weeks as 12 weeks plus 0 days is causing some problems. All our clients are offered specialist pregnancy counselling and STI screening free of charge as part of their care. And if people decide to attend for a post-abortion checkup, that appointment is free and can include a contraceptive consultation if the person wishes. A state-funded scheme to provide access to post-abortion contraception and contraception generally still hasn't been established. So people accessing the abortion service will have to pay for any contraceptive method they choose unless they have a medical card, which is one of the big pieces, I think, of unfinished business in terms of activism around reproductive health and rights. So I have no idea if I'm talking at 100 miles an hour, by the way, so I'll try to slow down. Yeah, to kind of give a broad overview of our first year of provision and the analysis we've done, it's broadly in line with what we'd expect. So people of all ages present to our service. You know, the majority are in their 20s and a high proportion in their 30s as well, but we have people on either side of that as well. People tend to present early. In our experience, generally around 6 to 8 weeks, most clients would be. And most women know their dates. So the law specifies that pregnancy has to be calculated based on last menstrual period. In our experience, women tend to know this information. And I think that's particularly important for the kind of Irish model because community provision doesn't involve routine ultrasound scanning. As Tiernan was saying, there is an option to refer for ultrasound, but it's not routinely done for every client. So we would refer, I'd say, approximately 50% of clients for scanning to kind of confirm dates. And in just a small proportion of those cases, the scan results indicate that pregnancies were more advanced than women had anticipated. And those can be the really challenging cases because in some instances, that means that women are either very close to or actually outside the 12-week gestational limit. And then in terms of the service, we find that uptake of post-abortion contraception is high, despite the kind of remaining cost barriers. There's also a demand for specialist pregnancy counselling and STI screening. These are not taken up by every single client, but I'd say about 20% take up counselling and about 50% take up STI screening. They're rough estimates. In our experience, abortion care is not a significant burden on hospital services. Less than 10% of our clients have been referred for hospital-based care. And then I suppose in terms of complications, so the most common complications would be incomplete or failed abortion or maybe instances of infection. And we found that our complications are in line with the international evidence, which again is really reassuring. So we would have particular concerns about how that 12-week limit operates in terms of kind of the logistics of arranging care for people who are close to the threshold, because that can be a very stressful experience for the individual patients and for the providers trying to ensure a hospital appointment in time. We're concerned for people who are excluded from care as a result of that threshold. And then there's also a cohort of people who accessed early medical abortion below 12 weeks, and then they have a positive low sensitivity pregnancy test post-abortion. And, you know, in a lot of instances, you would just wait and administer another pregnancy test. But if women have a positive test and they're close to the threshold, there is a concern that any ongoing pregnancy after 12 weeks cannot be dealt with. And this is what Kathy was alluding to in terms of the petition. And that we found that is a significant source of anxiety and for providers. And I think it's how this 12-week limit is operating and the kind of ticking clock effect is something we really need to be thinking about in terms of the review. I just want to touch on then, I suppose, in terms of more recent developments on the introduction of remote consultation during the COVID-19 pandemic. So I think this has been a really positive development. And I think what we saw was that the Department of Health and the government recognized abortion as essential healthcare, and they prioritized people's continued access to care. So I think the fact that it was determined that these changes could be introduced without amending the law is really important, and that actually kind of opens up a space for us around interpretation of the Act that's potentially very useful. And I think there's huge credit due to the Department of Health, the HSE, and the National Clinical Lead for Abortion Services in getting these changes introduced as soon as possible and rolled out. From our perspective in the IFPA, this was a huge piece of work, basically shifting service delivery from in-person to remote overnight, almost. And I suppose we recognised quite early on that there was kind of a need to build in some additional support. So we developed a series of videos explaining the new care pathway to women. We put together like a step-by-step guide that goes in the home care pack. And then our counselling team kind of took on an additional kind of information role to kind of talk women through what to expect from phone consultations. And the feedback we've kind of gathered from people accessing the service has been really, really positive. Women have been very happy with their interactions with staff and the level of information provided, and they've told us they feel very supported. I think women identify a lot of advantages to accessing care by phone, like what you'd expect: more privacy, no travel time, you don't have to take time off work or education, arrange childcare or other care. So a lot of that feedback kind of came back to us in our service. I would say as well, though, it doesn't suit everyone. Like, some people will always prefer to sit in a room with the doctor. So I think services need to be flexible. And I think a kind of blended approach allows us to be responsive to individual service user needs. So I think we should be arguing for an evaluation of remote consultation to kind of support its retention in the long term as part of a blended model. So the kind of interim model of care states that this is temporary and that it's only in place for the duration of the pandemic. And I think, putting that language in there actually kind of goes against what they did, which was, take a very patient-centered approach. So I think it really makes more sense to actually evaluate how this service has benefited service users and service providers and integrate that into services going forward. Sorry. I think then, in terms of what isn't working, the pro-choice movement has been really successful in the past few years, in particular, in kind of moving abortion out of this kind of toxic political silo and framing it as an aspect of people's sexual and reproductive lives. So we haven't kind of talked about abortion in isolation. We've talked about unintended pregnancy, sexuality education, contraception, the kind of bigger picture that influences the real life situations people find themselves in. And I think, though, many of us kind of on this call were probably skeptical of the political processes in 2016 and 2017 that ultimately led to the referendum. I think, like, the citizens in the Citizens' Assembly actually identified those linkages and argued for a comprehensive set of recommendations that were then taken up by politicians. Excuse me. So I think there's still a lot of unfinished business in this respect. So access to contraception, like, this is completely stalled. And it was actually raised in the Seanad yesterday with the Junior Health Minister, who said that COVID-19 had significantly disrupted this work. And, like, we are in a scenario now where coronavirus is going to be the excuse for everything forever. Like, there was a working group process last year. They published their report in October 2019, months before any of us had ever heard of COVID-19. And no work was undertaken to establish a state-funded contraceptive scheme. And that's just not good enough. Like, it's just not appropriate that in our services, we have to send women out the door with a contraceptive method that they were using when they became pregnant in the first place, a method that we know doesn't work for them. They know doesn't work for them because they can't afford the method they actually want to use. I think in terms of abortion care itself, as Tiernan already touched on, the mandatory waiting period, obviously, and the issue of protests, again, these are things where very clear political commitments were made around safe access zones and nothing has been done. I think we need to think about or talk more about choice of method. There is very limited availability of surgical abortion. I think only a minority of hospitals actually offer that choice of method. I think that's something we need to think about. And and be conscious that medical abortion doesn't suit everyone. And particularly in terms of home self-management, like, well, we know the international evidence that there's very high rates of acceptability of this and women are very satisfied. There are women as well whose circumstances are not suited to this. So if we see clients in our services from direct provision, so they might be sharing a room with a complete stranger. We see women in our services who are homeless and who are living in a single hotel room with their partner and their small children. Home self-management is not ideal in those scenarios, and those women should have a choice of another method if they so choose. I'm not going to go into the kind of post 12-week grounds, as it's kind of beyond our experience as a service provider, but I think it is something that needs a lot of attention and how those grounds are being interpreted. And I think the retention of criminal sanctions is definitely having a chilling effect on the interpretation of the health ground and the fetal anomaly ground. The last bit then, I suppose, in terms of what's unfinished is rogue agencies, again, which completely continue to operate. If you search crisis pregnancy in Google, the first ad you get is for HSE My Options, and then right underneath it is a rogue agency. Again, we were promised action on this. There was initial steps taken with CORU like 18 months ago to establish a regulatory board, and again, nothing has happened. So yeah, I suppose to kind of finish up, where do we go from here? I think an evidence base is going to be really crucial for informing the review process. I think we need to be able to back up our claims. I think a lot is happening in this respect. So as Kathy mentioned, within the IFPA, we have our own kind of research project supported by the Irish Research Council to kind of gather data on our services. The WHO is doing a piece of work on policy implementation in Ireland. And then the HSE, which I think is really positive, is funding a piece of qualitative research on service user experiences. And I know ARC as well has a piece of research, which I think hasn't launched yet. So I think it's important that all these researchers, that we're all kind of talking to each other. Something I'd like, I suppose, us to think about as kind of a community of activists and advocates is how we can show support for providers, particularly at hospital level. So some providers in obstetrics and gynecology have been completely marginalized within their working environments for their willingness to deliver this service. So how do we support those providers who have kind of, I suppose, put their heads above the parapet to provide the service? I think going forward into the review, the public and the political landscape is really challenging. I think in the current environment, it's really difficult to hold TDs and senators accountable for political commitments made prior to the pandemic. I think a lot of our political allies have left the pitch. Some didn't retain their seats. Others have moved on to different issues or portfolios. Our political opponents haven't. So I don't know if any of you are like as sad as me to be, spending your time searching Oireachtas debates, but it's predominantly TDs who oppose this service that are raising the issue in the Dáil. There is consistently hostile questions being tabled by people who wish to see this service dismantled. I think the public landscape is challenging. Even aside from COVID-19, public attention and interest has kind of very understandably moved on to equally pressing issues, right? Like the housing crisis, the abolition of direct provision. We're not going to see anything near the kind of levels of 2018 mobilization during the review period. I think we all know that. So coordination and collaboration between those of us working on it is going to be really key to securing positive outcomes for people who need access to care. I hope I didn't go way over my time, but I'm going to finish up there. Thanks.
That's great, Alison. You didn't go away over your time. You're fine. And I think you raised some really excellent points. I know that we've had discussions over the last year or so about things like access to contraception and the changing political landscape, and it is going to be something for us all to work together on between now and whenever we eventually have a review, and probably beyond it as well. because that's the nature of women's sexual and reproductive health rights. They're not just going to be like, oh, okay, you guys know exactly what's best for you. Why don't we just give you that? It's constant negotiations, I suppose. So thanks very much. And again, I just to remind you all to post your questions. We have a few in already. And so I'll just introduce Donna. Donna is with the BPAS, which is sort of like the UK's leading not-for-profit abortion care provider, and Donna's been with them for 15 years. And during that time, she's had specific responsibility for supporting and facilitating Irish clients who access abortion at BPAS. Donna has worked closely with agencies in both the Republic of Ireland and Northern Ireland to deliver and improve care for women who, for many decades, as we know, were forced to travel to England. And as we've seen from the UK abortion statistics that were released, women are still traveling from this island to England for abortion care. And although the numbers needing to travel are smaller, Donna continues to provide support to those people. BPAS provided data, client stories, and presented evidence to support legal changes that have taken place in the Republic and in Northern Ireland over the years. And so I'll let Donna take it from here. Sorry, Donna, just to let you know, you're still on mute.
Right, okay, sorry about that. The technology always lets you down, and when I came in, I obviously found out that I was the only one with slides. So I just need to say, as a matter of housekeeping, I've got a contrast issue on my camera. So if I go dark, I'm still here. I'll end up looking like an anonymous source from a news article, but I am still here. And the reason that I've chosen to have slides is I've got some data to share with you. We've done an evaluation of our Pills by Post service that I'd like to share with you. So I wanted to say thanks very much for inviting us along. What has been very heartwarming to listen to with Tiernan and Alison is this is the first time that I've come to an event, and I do come every year, as Kathy was saying, and heard stories that are shared experiences with us. So just this morning, we had a powwow because we've been having protests outside of our clinics for 40 Days for Life. And we had a phone call from a load of pro-choice activists telling us that 100 of them were going to turn up at our Brighton clinic this morning to face up to the anti-abortionists. So we were trying to prevent a scuffle outside our Brighton clinic this morning. And to also listen to Alison say about the kind of materials and collateral that they've been putting together to support women who are having tele consultations. So it's really nice to hear that. Usually by this point in the march, I know that I'm looking for the pub and ready for a couple of gins. So I'll try and scooch through this as quickly as I can. Just 2 secs. So my talk is made up of 2 parts. Kathy asked me to talk specifically about our implementation in England and Wales of our Pills by Post service. So obviously we'd been doing telemedical abortion for a while, but we've actually started delivering the whole service to women at home. And then the second part is I'm going to talk specifically about women who had to still travel during the lockdown and who are still traveling, actually. Right, okay. So first, just a little background. Kathy just gave me a little introduction there, but BPAS is a not-for-profit independent healthcare charity. We've been providing abortion care in the UK for more than 50 years. We take care of more than 100,000 clients per year, and practically all of that's on behalf of the NHS. We've got about 80 clinics nationwide, and we're the innovators of Pills by Post, our EMA service at home. And I'm going to talk to you about that as we go through. We provide the central booking service for Northern Ireland on behalf of the English Government Equalities Office. We provide services for booking appointments for any client who lives in Northern Ireland who needs to travel for England for treatment, and that's with any provider, whether it's us, NewPass or MSI, and in some NHS provisions where there's a medical difficulty for a client. So prior to the regulations coming in the north in April, we were booking about 1,400 clients travelling per year. And with the Republic, prior to the law change last year, we were booking about and taking care of about 1,800 clients. But last year, I'm very pleased to say that we only took care of 146 women from the Republic of Ireland. But as you will hear, those 146 are often quite complex and are even more stigmatised. So going into Pills by Post, it actually starts in Northern Ireland. We had been developing this model of care for quite a while. It'd been in development, but to be honest, we're thinking that we'd be implementing it when we get decriminalised in England. Never did we think that we'd have the opportunity to implement it in Northern Ireland first. And I'm really grateful that we did, because it enabled us to respond to the COVID lockdown situation, turn in actually its implementation into one of the silver linings to come out of the pandemic. And Alison was saying something like that, you know, this situation has provided us a golden opportunity to evidence what delivering care at home can really look like and how safe it can be, how safe it is. It required quite a few U-turns from our Department of Health, something that our government's very experienced at lately, but I'll talk a bit more about that later. So prior to the regs changing in Northern Ireland in April, we were still routinely scanning, unlike you guys who hadn't implemented routine scanning as part of your service implementation last year. We were still doing that. And whilst we did have a plan to start migrating out of that into a scan as necessary program, we hadn't implemented it across our full patient population. So we needed to accelerate that if we were going to implement Pills by Post in Northern Ireland. It took us some time to get to a service design in Northern Ireland. So they decriminalised in October, and ideally we would have loved to implement sooner, but we had commissioned a commission of Medibon, which is a packet that includes both mifepristone and misoprostol, and it took us some time to actually get it into the country. It got stuck in customs in January this year. So there was that challenge first off, and then secondly, we wanted to take some time to make sure that we got it right, because this was the first time a UK provider had delivered complete care at home. We wanted to make sure that our clinical guidelines and our safeguarding guidelines were robust. But we finally got there, and we launched Pills by Post in March in Northern Ireland. I observed the first call, actually. So I sat next to the midwife that was talking to a client in Northern Ireland when we launched, and I was quite excited. And it came to the point in the call where the nurse says, okay, we're in a situation now where we can either offer to send the pills home and you'll take care of yourself with support from us, or you can travel to England for care. And the client very undramatically said, oh, I'll have them at home. And so I'm in the background thinking, I was expecting her to actually say, am I allowed to do that? Or is that legal? But no, it was a very, very natural option for her. And that kind of says to me just how normal clients expect this kind of direct and remote care to be in healthcare these days. So the process actually in Northern Ireland, when we launched, was clients were having a telephone consultation, and we've been doing telephone consultations with Northern Ireland clients for quite a long time. If the client was under 18 years of age or a vulnerable adult, they had a video call. And then specifically for Northern Ireland, after all the paperwork had been done and consent had been taken, they received a call from a Northern Ireland doctor that we'd employed in Northern Ireland. And we did that on purpose to ensure that we were responding to the specific needs of women in Northern Ireland. That was a key part for us of Pills by Post, actually. So although it was a short period of time before the regs came in that we were delivered, the feedback that we got from the clients was really good. And the volumes that we got during that period were quite significant in the context of normal Northern Ireland volumes. So that was quite interesting. But as I said before, the regs were coming in early April, which absolutely prohibited us from sending the pills in the post legally. So we delivered for about 3.5 weeks, and then we had to stop. The regs themselves, they've got that element in it of our law, which we are least fond of, which is that the mifepristone needs to be taken on licensed premises. And it is the bit of our law that makes care potentially unsafe for clients who have got to travel after they've taken their first set of pills. And so it just completely put a kibosh on us being able to send out to Northern Ireland. So COVID came, the lockdown came, and that was in the week of the 21st of March. And we were told in England and Scotland and Wales, and of course Northern Ireland, that we were still able to travel for medical appointments, but people didn't, they didn't come. We saw a massive drop off immediately across both clients who were accessing care from Northern Ireland and in Britain. And you can imagine those that were traveling for flights, those that were traveling, flights and travel arrangements were being cancelled left, right and centre. It was a true nightmare. So we began lobbying the Department of Health, and we showed them, albeit the short time that we were delivering, how we were delivering Pills by Post in Northern Ireland. They were very interested in that model. So the Health Secretary here in England has the power under the Abortion Act to license any premises as a legal place for an abortion. And again, Alison was saying that was what was good about the flexibility in the Republic around interpretation of the Act. Here, the Secretary of State for Health, it's completely within his gift to say where a woman can take her treatment. And if Matt Hancock was going to give us that permission during lockdown, it meant that we could protect at least the largest volume of clients who are accessing abortion under 10 weeks to be treated safely at home. It also meant that we were preventing what had already started as this bit of a tsunami of abortion demand, because lockdown occurred, people stopped traveling, they didn't come for their appointments, even though they were allowed. And we were like, what's going to happen with that when the lockdown finally becomes lifted and we get this, deluge of volume who are all wanting later abortion? And that causes its challenges in itself. The other challenge that we had during COVID was that at worst, about 50% of our clinics were shut. And that wasn't because staff were getting sick, it was because these clinics are based in NHS locations that stopped allowing face-to-face consultations. So the situation was just getting worse and worse and worse. And we needed to convince Matt Hancock that this was the right thing to do. So he said yes. The Department of Health went out to the press, and 24 hours later, they did a U-turn and said no. And everybody was in a tears. And that's when the likes of the RCOG and other providers and other organisations basically applied as much influence as they could with the Department of Health to change that ruling and allow people to stay at home and access their care while our government was trying to keep people at home and keep them safe. So about a week later, approval finally came and we started delivering in England and Wales, and that was the whole of our EMA service. Were able to access care safely in their home, but sadly not in Northern Ireland because the new regulations had prevented it. We implemented Pills by Post nurse midwife led telemedical abortion in England and Wales at the beginning of the 6th of April, the week beginning the 6th of April. We were already doing teleconsultations, as I'd said. We've been doing them for about 2 years. And of course, we were doing them for clients traveling from Northern Ireland and the Republic of Ireland. And prior to COVID, about 17% of the consultations that we were doing of the 100,000 clients that we take care of each year were over the telephone. So you can see that predominantly we were still doing face-to-face in-clinic consultation. But in that first week in April, we went from 17% over the telephone to 97% over the telephone. We also implemented the scan as necessary guideline across the whole of the patient population and began sending out the pack where clients were medically eligible. It was basically the exact same service that we'd been delivering in Northern Ireland. And there was something perverse about the fact that we were now able to deliver it in England and Wales, but not able to deliver it in Northern Ireland. So the process in itself is everyone gets a telephone or a video call with a nurse or a midwife. If the client is unsure of their dates, and like Alison was evidencing, most women are quite sure of their dates, but for those that weren't, we still bring them in for a scan. Or if there's a safeguarding raised that requires us to see that client face-to-face, we would still bring them in. And about 20 to 25% of our EMA caseload are coming into the clinic for a scan. But if they do, they take a packet of pills away with them rather than taking their first medicine in clinic. And then what happens after the telephone consultation occurs is that there's a review of the medical data that's taken, and the legal documentation is checked and signed by 2 doctors, because of course the Abortion Act still requires us to do that. And we do that on an electronic system, so it's almost instantaneous. A prescription is then issued. We engage the services of a direct pharmacist that sends all of this out directly for us. And you can see the pack here fits through the letterbox. It has the Medibon, which has got both medications in it, both the Mifia and the misoprostol. It has the pain management medication codeine, if that's indicated. Full instructions with the links to online support. Again, like Alison was saying, we've been developing a lot of different ways in which clients can access support. And we provide progesterone-only pill in this packet. It's been quite difficult for us to continue with our contraception offering in the same way, as you can imagine. And certainly we are targeted with our NHS commissioners to be delivering as much LARC as possible. That's not possible when you're providing a fully at-home service. However, what was most important during, certainly during this period, was to make sure that women were at least able to access their abortion safely. So the next step is 1 to 3 days later, a Royal Mail tracked packet is received. And we ask women permission right up front. If they give us permission, we will text them to say that their packet's gone in the post so that they can track the packet themselves, so they can have an idea of when they need to be at home. We provide 24-hour medical helpline and complete full aftercare. Pardon me. Oh, pardon me. And during the first quarter, we delivered almost 17,000 pills by post, which equated to about 80% of our total early medical abortion service during that period. So you can see the numbers are big. This is just a very brief example of some of the comms that we've produced to enable us to enable it to be as accessible to as many clients as possible, easy to understand, and quite step by step, again, like Alison was saying. So that's the service in itself. What was the outcomes of us delivering that care? We'd gone from a almost in-clinic based organisation to a completely remote service overnight. And we don't like the word remote because it sounds like it's not caring, but I mean, in essence, that's what it is. You're not seeing the client face to face. So we had some national figures come out, not last week, the week before, from the Department of Health, which is an unusual occurrence. And it evidenced that during the COVID-19 lockdown, owing to pretty much delayed demand, so this is people who decided not to travel, not to come out of home during the lockdown for their abortion treatment, and pre-existing wait times, that in April, we provided 23% more abortions than we did in March, right? So that's not more women accessing abortion, it's just pushing all of that demand into a smaller place. And in the first quarter of our Pills by Post service, the national waiting time for early medical abortion was 2 days. That was a reduction of more than 50%. Yeah. So what we were able to do was all of those in-clinic staff that might do consultation and other things were actually just dedicated to doing Pills by Post. So we were able to reduce the waiting times by at least 50%. And the other really good thing to come out of this was that the average gestational age was brought down from 7+1 weeks to 6+2. Now, that might not sound like a lot, but when you're talking about the best clinical outcomes for abortion, we all know that the earlier an abortion can take place, the safer it is. So, impact on client. We do a service evaluation about 14 to 21 days after the client has actually finished treatment, and we were able to mobilize a specific evaluation about pills by post really quickly. And as you can see here, of the clients that we surveyed very early on, 96% of them were telling us that they were satisfied or very satisfied with their experience of pills by post at BPAS. And then 82% of them were telling us, you know, if in the future they need abortion again, that their preference would be to have a telephone consultations and pills by post. So clients are telling us that they prefer it. That's great. As I said before, the DOH had published some stats last week for us, and it evidenced that for the first time ever, 79% of all abortions were EMAs in the first 6 months, and that's a massive achievement. It's actually one of the targets for NHS commissioning, that they try and get as many clients through as early as possible. So that's been a great benefit. And I understand that in the Republic, at least, you've seen an increase in clients requesting the second appointment face-to-face. We're seeing the complete opposite to that, actually. Clients are very happy to know that they haven't got to come anywhere near abortion clinics, especially when there might be potentially protesters outside. So that seems to have been a benefit that clients tell us about. So in essence, our clinical, our safety statistics, our client feedback, our NHS Commissioner feedback is telling us that although this model was implemented at speed and in response to COVID, we need to retain it post-COVID, as it's better for clients. It is safe and the women prefer it. And there is still much work to do, but it also looks like that it might be less expensive than in clinic services for the public purse. So the next steps in England is that our government has committed to undertake a public consultation to ask if the legal permission should be retained. And that consultation is supposed to start next week, but I don't know whether it will. We're doing the best that we can. We're having conversations like this. We're presenting as much data as we can to support pills by post continuation. And hopefully by the spring, we'll know if we can continue post-COVID with this highly acceptable model of care. So that's the end of the review about pills by post. It's a bit of a gallop, and I'm sure I'm talking at great speed too. So please do ask any questions that you've got about that in that session. But I was asked to specifically reflect on the challenges of Irish women who had to travel during the lockdown and who are still continuing to travel. So frankly, it's been a nightmare, as you can imagine. Immediately as COVID kicked in and the lockdown occurred, we saw a 50% decrease in clients of more than 10 weeks traveling at all. So that wasn't just from Ireland, that was traveling around Britain as well. And you've got to ask yourselves at that point, what are those clients doing? Are they continuing pregnancies, or are they accessing any other kind of help? Which is a little scary. So as I'd said, in Northern Ireland, once the regulations came into force, there was a few weeks where nothing was happening. So we were delivering care, pills by post, to British and Welsh women, but Northern Ireland clients weren't accessing any care. They were pretty much left in limbo. So we took some legal advice. We looked at the health emergency elements of the regulations in the north, and we concluded that in good faith, we could reinstate our pills by post service in Northern Ireland. And we did that for about a week until the local service was up and running in Northern Ireland. The in-clinic service was being set up there by clinicians and advocates. And the Chief Medical Officer, Michael McBride, wrote to the health trusts in those first few weeks of April to say that they needed to start providing services as soon as possible. Informing Choices Northern Ireland provide a central access point for all clients less than 10 weeks gestation. And we were informed by the Government Equalities Office, who funds the Northern Ireland Central Booking Service here, that once the local service was up and running, all clients less than 10 weeks should be referred to the NI local service. And that's where we are now. So all clients more than 10 weeks are still funded to travel. And those that want to access a surgical service less than 10 weeks can still travel. But as you can imagine, that wasn't easy during full lockdown. Flights were being cancelled and hotels were being shut. And so in order for us to get people to England from Northern Ireland, the CBS resulted in booking people on a ferry, an overnight ferry from Belfast. They were then treated in Liverpool or Manchester and booked back on an overnight ferry back to Belfast. And during the height of the lockdown, it really was the only way that we could get people into the country. It was awful, but you know, what could we do? What we had got was dispensation from the Equalities Office to provide as much comfort as we could. So we were, for the first time, able to fund taxis. We were able to fund cabins. So it wasn't great, but they were still getting in, and it was about 50%, and it still is about 50% of people who would normally be traveling over 10 weeks gestation. So it's, the numbers traveling from the north now are in pretty much single figures, and they've been pretty much like that since the local service started in the north. We have had no indication yet what the plan is with the CBS after next March, because the GEO's funding ends next March, and whilst we've asked them, it's important to understand that whilst there isn't a commission service in the north, it still looks like women's health will be the political football it's always been up there. There are far more people qualified than me to talk about the current political and funding situation up there. But I would say, I feel like it's a real wasted opportunity. We had a real chance in Northern Ireland to evidence what a decriminalised environment can do in terms of providing a real client-focused abortion service. So there is some way to go, but it is a start. So that's the north. So Republic of Ireland clients, it's pretty much the same experience during COVID, with the addition to fund their travel and their treatment. You know, that's always been the case. It's no different. However, these cases that are now traveling to us, that 146 that I talked about last year, are definitely more complex, and there's been some horror stories, and I'll give you a couple of examples. There was one woman who was 19 weeks. She travelled to London with her mum. It was a fetal anomaly. I don't know why she didn't get access to care in the Republic, because it was a fetal anomaly. But she decided, I don't know whether it was a timing issue, but she decided to book with us and fund her care. She did get to London, but just as she got to the hotel had shut its doors to clients, to all customers, in fact, and they wouldn't even let her in to make a call so that she could find another solution. So she called us, and she got put through to me. And while she was talking to me, she was sat on the pavement outside the hotel crying. And she said, it was heartbreaking, all I wanted was somewhere to have a cup of tea with my mum so I could work something out. We got her an Airbnb, and she was treated the next day, but on the way back to the airport, her flight was cancelled. You couldn't make it up. And she was fortunate. She was a fairly resourceful woman. She managed to sort a train up to Holyhead and a ferry back to Dublin, but she must have been travelling for days, and she must have had the resources to be able to do that. I can't imagine that if you were a client and you came here, you know, with just enough money to get your logistics through, that should that happen, you'd practically be stranded. So the clients that are travelling for care in England might be small in number, but as I said, they are often complex. And another example that we've had is an Irish client, unfortunately, has ended up with a hysterectomy in England. She had placenta previa. She hadn't been scanned, obviously, in the early part of her care. She did access an EMA down in Cork, and of course it failed. And this was something Alison was talking about as well. We're seeing women travelling because they've had failed EMAs. And that for us is a real concern, because clearly the drugs that you take in EMA are evidence to cause birth defects. So it really is a potential failure of duty of care, really, by leaving these women to be pregnant. But this particular client, we couldn't take care of her because of the placenta previa, but we did manage to get a referral into an NHS hospital. They wouldn't treat her unless they'd scanned her, for obvious reasons. So the poor woman had to fly backwards and forwards 3 times before she had her care. And then she ended up, unfortunately, with a hysterectomy. And now she's got a bill of about £7,000 hanging over her. So it's all these small things that add up to make that whole experience horrific, absolutely horrific. So in general, the women that do come to us do give us information about the fact that often they've experienced poor scanning. And I think Tiernan was saying something about that earlier. Cork has definitely been a place where they've talked about their poor quality of scanning, not just in terms of accessing it in the first place, but also when they've had a scan, they've been told they're over the limit, they travel here and then we scan them and they would have been under the limit when they would have been here at home. So that's the story that comes across quite loud and clear. And I guess the other thing that concerns us about the women that travel from the Republic is these women who are coming with medical complications that meant that potentially EMA might not have been the best solution for treatment for their needs early on. So the placenta previa one is a good example of that. So there is one more thing that we're doing. Alison already highlighted the elements of research that's going on. There's the piece of work that Dr. Catherine Conlon's doing at Trinity. She's asked to for us to be involved in that, and we're going to start collecting data and sharing data with Catherine soon. So Irish issues, it's always more complicated. The expense of travel, not being able to access care at home often makes these women tell us that they feel even more stigmatized and alienated. And I know that advocates here, advocates in the Republic, when the Act was going through and the service was being set up, anticipated that might be how women feel who are forced still to travel. And we're quite happy to support any work that's going on to help address that inequality. So just in summary, although the numbers travelling for access is small, Cathy already said it, we're very proud to carry on supporting and advocating for women who travel from the Republic of Ireland and Northern Ireland, and are very proud to do so. And for us, I guess, just to finish off, in England, COVID has presented us, as Alison was saying here too, with an opportunity to prove that abortion at home is safe, and therefore pills by post has been one of the rare successes of COVID, and we've got to keep it at all costs. Thanks very much.
Thanks so much, Donna. I'm just trying to start my video again here. There we go. So I think sort of like a big takeaway from all of the speakers today is that obviously while community provision here is working quite well, there are a lot of gaps in care, and that's something that we're going to have to try to work to resolve. Those examples, Donna, that you gave of women traveling are horrific, of course. And I often reflect on the fact that during our referendum campaign here in Ireland, the stories of people involved with the group terminations for medical reasons were sort of front and center in the narrative, and so people often voted, based on hearing these very upsetting and tragic stories. And unfortunately, for a lot of people, they're still in the same boat that they were before our laws changed, and it's really it's upsetting to think about that that these people are still left behind and obliged to make that journey, and obliged to make that journey on a freight boat is really just is terrible. but it's great also to hear Tiernan's account of how well that community provision is going, and that you know, for an awful lot of women, they're able to access the care that they need. I did find it interesting the difference between, Donna, you sort of saying that the majority of women who access pills by post were really happy not to have to go to anywhere, essentially, to, you know, they didn't have to go to a clinic to access that care. Whereas I have heard anecdotally that women in Ireland so far have elected to have their second consultation in person, and that's something that they want. And so what Alison said about this blended approach and trying to maintain it and ensuring that women have choice in the care that they receive is very important. I'm just going to go to some of the questions that we've had in. And so the first one is a question, and again, any of the speakers who feel that they can answer it should do that. And it might be the case that it's not possible. But first question is about the extension of prescriptive authority to practice nurses and or midwives. This is something that the WHO recommend, and it can help with conscientious objection where this is a barrier. What's the likelihood, do you think, that that authority would be extended to practice nurses or midwives, or is that like another campaign essentially that we would have to work on? Don't jump in all at once to answer the question. If you just want to raise your hand, then you can come in to speak to it.
I mean, in the UK, we've been delivering our care nurse and midwife led for a long time, but the Act requires us to still have a review by 2 doctors. And we've been able to, I mean, obviously I can't speak for the prescribing in Ireland, but our experience is that we've built services despite the Act. So we've designed the operation in a way that, you know, the doctor part of it is the smallest part, and because recruiting nurses and midwives at volume is easier than doctors, so we use our doctors for what we really need to use them for.
Do Alison or Tiernan have anything to add there, or will I move on? Oh, Tiernan, there, you're just muted.
The difficulty in the Republic is that the area of nurse practitioner prescribing is so poorly developed already that it presents huge problems. In Doctors for Choice, we would feel very strongly that we would support any extension of prescribing to midwives or practice nurses, but there is a very big practical issue that we're many years behind Britain in that area.
Okay. So, and again, so the next question is about the experience of people who are accessing abortion at 10 to 12 weeks in hospital. So again, this mightn't be something that that you guys can speak to, but the question is, how many providers and hospitals offer surgical abortions or aspiration, sort of that 10 to 12 week period? Do you know?
Well, again, unfortunately, my experience is just with Holles Street, and again, it's a very positive experience. I got a phone call from a woman on, 5:30 on a Friday, who was on the north side of Dublin, and she'd been to her GP, and the 2 of them were pretty sure she was 11 weeks. So obviously, for me to see her or to attempt to scan would have been a mistake. So I simply emailed the annex in Holles Street, and she was seen on the Monday morning so that they could scan her on the spot. And if she was 11 weeks, she could then access surgical abortion. So that's the sort of setup that is perfect. But unfortunately, there would be large gaps around the country.
Yeah, I agree with that. And I think there's 10 maternity units providing the full service, but my understanding is less than half of those are actually offering choice of method. But I think that the question also points to a larger problem we have around this service in terms of data collection. Like, we really don't, like, we know that there's one county where there's no community provider, but like the actual geographical spread of services, we don't know what that looks like. You know, we hope that it is sufficient, but it's very hard to get that picture. And I think similar with hospital, that, like, yeah, I'm concerned about how data is and isn't collected about this service, and the information we choose to publish. And, you know, I think that's something, again, we need to think about as part of the review.
And so we did have a question in as well about is Sligo, that's the county where there's no community provider. The person who sent in the question basically was wondering if you guys had any, I don't know, like ideas as to maybe why that's the case, or I suppose if there's anything that we can do to support GPs in the area so that there is a community provider in that region.
Well, the difficulty is that there are many units, hospital units, that will not provide. And at a macro level, we have a situation where this is a legal service that all women are entitled to. And if units in the state which are funded by the taxpayer are not providing the service, well, obviously, money should be withheld from their annual budget and handed over to a private provider, if such exists. And unfortunately, I don't think the government is prepared to go down the line of having provided the service to make sure the service exists. So there's a lot to be done there, and I don't see it being easy.
Okay, just having a look here. So another question, does Tiernan or anyone else know if there is any work done on introducing a transparent referral system?
Now, I wonder what's meant by transparent referral.
I don't have that information to hand. I just have the question as it's here. Unfortunately, I don't know if the person who submitted it wants to qualify a bit more.
I can if you want.
Yeah.
Great.
Hi, Camilla Fitzsimons. I asked the question. What I mean is where a GP refuses to provide, to prescribe because of conscientious objection. The law states that they have to refer, but my understanding is that it's not clear how that's happening at the moment, or if it's even happening at all in some instances.
Yeah, I'm not sure that is a problem, because the vast majority of women, I believe, ring My Options, and My Options give them the name of, it was 2, but now 3 geographically nearby providers. So the woman might get a provider near where she lives or near where she works. So I don't think many women approach their own GP about this because they simply don't know the stand of the GP. And if they ring My Options, we don't know what's happening about conscientious providers and whether any steps will be taken against those who refuse to refer on. But I'm hoping that the wonderful My Option.
Sorry, we sort of lost you there a bit, Tiernan, but from what I gather, it's you're sort of saying that maybe conscientious objection isn't a barrier because people find out who providers are locally through My Options.
I think that it is, though, because
Pardon, Camilla?
well, I know that the one of the UK organisations, I think the Abortion Support Network, when they published their experiences, they said that they had supported women who had been GPs almost acting like rogue agencies who had given them misinformation about how pregnant, how far pregnant they were and things like that. So I'd like to think everybody is approaching my options, but I don't know.
Not
Again,
everyone
as
will.
Alison said, we don't know. We don't know.
And that was pretty, sorry, Tiernan, pretty shocking to hear about private companies that have been contracted to provide these scans, and then women ending up with BPAS, discovering that actually they would have been eligible for a legal abortion without having to travel. That's pretty pretty damning of the service in itself. Like you said, Camilla, it's almost like they're behaving like a rogue agency. Sorry, Tiernan, you had your hand up there.
We estimate that the number of GPs who are conscientious objectors is probably about 10%. There would be a larger group of convenient objectors who are simply GPs who do not choose to provide the service, but are supportive of abortion. And they will usually just refer directly to someone in the area that they know provides. But it is a difficulty with
Sorry, Tiernan, I think we've lost you again there. So I'm just going to Alison. Sorry, yeah.
Yeah, just to add on the my options list, I think I'd like to see my options engage with providers again about how they feel about their details being accessible, because certainly I know when GPs signed up, they were asked about sign the contract. There's certain GPs who are only providing to their existing clients. There's others who don't want their details known. That was in the early days of the service. I think it would be useful, like almost 2 years into provision, to actually look at how providers feel about it being known that they provide the service. And if we can make some of that information more readily available, I think that would deal with some of the, prevent some of the harms of people engaging with people who don't support the service.
So I'm just conscious of the time. There's only one more question in here. And I think that it's sort of aimed at everyone. So if you had 2 minutes caught in a lift with a government minister of your choice, what would be your most urgent request of them? So Alison, I'll let you go first because you're grinning. You obviously have someone in mind, I'm sure.
Just talk 100 miles an hour. I suppose just the key point is that this review next year is about enhancing access. We are not rerunning a referendum under any circumstances, and we need this review to be evidence-based and informed by the experiences of service providers. We need to follow through on political commitments that were made in 2016, 2017, and 2018 to improve access to contraception, to improve sexuality education, to eliminate to introduce safe access zones and eliminate rogue agencies. And I think that was quite quick, actually.
Yeah, that's like your elevator pitch. You probably have
You
to
do it in
stand
2 minutes.
awkwardly with them now for while it moves between levels. Tiernan, do you have anyone in mind if you had the opportunity to speak to a government minister of your choice? What would be your most urgent request?
I think GPs would be agreed that the urgent request is free contraceptive services.
Yeah, that makes sense.
That would come in because we should have free general practice service. It would total NHS, and by definition, all women would be entitled to free contraceptive services. So that's the big one for us.
And what about you, Donna? I suppose you can pick a minister from anywhere.
All right.
Anywhere.
Northern Ireland, I put them all in the shaft, not the lift. I think I'd say you've missed such a great opportunity to build, as I said in my presentation, a real client-focused abortion service. Pay for your services. Stop expecting people to do stuff for free for you, which is what's happening with the Northern Ireland in local clinic at the moment. These doctors and nurses and advocates are doing what they're doing out of goodwill, and that can't carry on forever, and that's shameful. So that's what I would say. Pay for your services.
I'd just like to thank Alison and Donna and Tiernan for joining us today. It's been a really interesting and informative chat. And I'd like to thank everyone else for joining as well. If you feel motivated by the conversation that we've had today, do please get in touch with ARC. We're not going anywhere. And obviously there's still a lot of work to do. So if you're interested in joining us, please just drop us an email, contact us via any of the social media networks. And also just flag that one other activity that we have tonight is our co-video party. So we'll be pressing play on Reversing Roe at 8 p.m. and one of our volunteers will be live tweeting along with it. So if you're up for some righteous indignation and rage of a Saturday evening, you'd be very welcome to join us. Thanks everyone again so much, and I'm sure we'll be seeing more of each other soon, no doubt.
Thanks, Kathy.
Thank you.
No problem.
Thank you.
Bye.
Bye everyone.
Thanks, Kathy. Good luck.
Bye.
Thank you.